All right, I would like to thank Emily and Seth and Perry for organizing yet a wonderful conference. I hope you are enjoying yourselves. I can testify that the speakers are enjoying themselves. It's a rare occasion for us too to get together and hear each other talk. I will be talking today about mentalization in BPD from bench to bedside. And as Emily said when she introduced the speakers early this morning, I will be talking a lot of bench. So I'll be presenting quite a bit of science, but I'm hoping to really draw it through to the translational endpoint of bench to bedside to also give you some sense of mentalization in the context of bedside. And when I present data, I'm really going to try and focus on adolescents with borderline personality disorder to stick with the theme of today. So what do we mean with bench to bedside? What we really mean is translational research. The official definition is the effective translation of new knowledge, mechanisms, and techniques generated by advances in basic science research into approaches for prevention, diagnosis, and treatment of disease. And so what we do in translational research is we take discoveries in basic science and we translate that to be useful in clinical practice. Now, because this is such a worthwhile endeavor, the NIH founded several clinical translational science centers in order to further this agenda. And you can see there that quite a bit of money has been spent on these translational research centers. However, just a small portion of that funding has gone to mental health. So only about $320 million out of nearly $4 billion have gone to mental health in trying to establish a translational research base for treating mental disorders. And at the bottom of this mental health focus is personality disorders. So it brings up the question, why is it that there is this lack of focus in translational research for personality disorder and for mental health in general? And when we start unpacking the criteria for translational research, it becomes apparent how difficult it is to do good translational research. So I'm going to stand still just a little bit at what are the criteria for translational research, and we'll understand why it's so hard to do this in personality disorder research. So the first criterion is that translational research need to be from bench to bedside. So we need to develop all of these tools and mechanisms in basic science, and then we have to translate it to clinical practice. But it has to work the other way around too. We have to take ideas that come from clinical practice and we have to translate them back to the bench and use them to inform work at the bench. Discoveries in translational research is not always biological in nature. Related to the third point there, Grigorenko talks about healthy reductionism. So translational research is not all about reducing what we do in clinical practice down to biological mechanisms. It also takes into account interactions between the environment and biology. A fourth criterion of translational research is that it has to be interdisciplinary. So we have to have a conceptual model that can guide the interdisciplinary nature of translational research, and we have to have a construct that can move easily between disciplines. So having a construct that cannot be easily talked about in biology and cannot be then translated into clinical practice is a problem for translational research. The integration of biology does need to happen. We want to see that this construct can be studied across multiple levels of analysis, from cells to neural networks, through to behavioral phenotypes, and through to our clinical interventions. Good translational work is always developmental, and the reason why the NIH has decreed that it should be developmental is because we know that the earlier we intervene, the more effect our treatment and our interventions have. So good translational research has to be downwardly extended to children and adolescents. Development of pathways to personalized medicine is another criteria for translational research. We have to be able to, in translational research, work out what works for whom. So we have to be able to have a construct that we study that we can look at in the context of mediators and moderators. Does this work for men? Does this work for women? Does this work for older people? Does it work for younger people? So again, a flexibility in the construct that we identify for translational research that can move easily across development and across different types of populations. Related to that, it has to be a construct that we can study in typical populations and in atypical populations. So we have to find constructs for translational research where we can pick up differences between healthy people, but also differences between people who have problems, and then between those two groups. Finally, translational research must lead to measures or instruments that are off the shelf and that we can use to track outcome and treatment. So there's no use in identifying something at the bench that we then translate into our treatment that we then can't operationalize in our treatment to track treatment outcome. So you can see translational medicine requires a lot from psychiatry in order to make itself relevant in the context of translational research. If we put all of this into a model, this is what you see. You've got a disorder there at the top. You want to be able to look at genetic variables that associate with that disorder, so that's really at the bottom end of the translational spectrum. You really want to translate those genetic variables into a neurobiological endophenotype. So that will be, for instance, a brain circuit. You want to be able to then further translate that into a neurocognitive endophenotype. So that will be what neuropsychologists test when they do testing with patients. You next want to translate that into a behavioral phenotype. You want to be able to describe the behavior, perhaps through a questionnaire-based measure. And then you want to be able to translate that into a therapeutic target that you can talk to clinicians about, that they need to go target in their interventions and so forth. In addition, we acknowledge that all of this is influenced by the environment. There's going to be an interaction with the environment, with this cycle. It has to be relevant across development in typical and atypical populations. And finally, it has to have the outcome of measures of malleable treatment targets. So there needs to be a pragmatic outcome here that people can use off the shelf. So a tall order for psychiatry. And as you can imagine, there are not many constructs in psychiatry that have been successful at this. I'm going to just give you as an example one construct that has probably been most successful in the context of depression, and that's reward function. We know that there are certain genetic associations with reward function in the brain that's specific to depression. We know that we can put people in an fMRI scanner and we'll see reduced striatal responses in their brains. We know that that is associated with reduced reward if we give them neuropsych testing. We know that we can give them the behavioral activation scale at the behavioral phenotype, and we can get that behavioral phenotype in the form of anhedonia. We know then that we can target behavioral activation in our therapies, and we've therefore completed this translational model for depression through focusing on this treatment target of reward function. So that's just to give you an idea of what we're shooting for in personality disorder research and borderline personality disorder in particular. So what I'm going to do in the rest of the talk is I'm going to evaluate whether mentalization has potential as a translational target. So I'm going to look at what do we know about mentalizing thus far, and I'm going to evaluate whether mentalizing can actually function as a translational target in this sense. I'll be talking naturally about some of the work we've been doing, but I'm also going to touch on some of the work that comes out of other labs. And I hope to really end at this therapeutic target point over there. Does this work? There we go. And really give you a sense of the full translational spectrum as we go along. All right, so just briefly, mentalization. has been used in the psychoanalytic literature since 1970s, according to some reports even earlier. And there it was defined as the process of mental elaboration, including symbolization, which leads to the transformation and elaboration of drive affect experiences as mental phenomena and structures. So quite dense language to really get to the point that we are people with minds and that the mind means something. That we can look to the mind to create meaning and to make sense of what happens to us. This concept is then picked up in the 1990s. This is certainly when I started working in this area. It was first picked up in the developmental literature and then picked up in the neuroscience literature and therefore started gaining mainstream status. Often used interchangeably with the concept of theory of mind, which refers to the capacity to interpret behavior within a mentalistic framework, to ascribe thoughts and feelings, ideas and intentions to others, and to employ this ability to anticipate and influence behavior. So mentalization is slightly broader than theory of mind because, as Arietta said earlier on, it also includes reflection on your own mind and not just the mind of the other person, but also reflecting on what's happening between two people. I think that's what social neuroscience is trying to do right now, is trying to work out what happens in the space between two people. In CBT, we've often looked at social cognition, but it's usually a property of the individual rather than a property of the relationship. What mentalization does is it takes it out of two people and looks at the space between two people and trying to reflect on what happens there with both minds in mind. All right, so first criterion, translational research needs to be multidisciplinary. And what I've done in this slide is simply list the fields that are studying mentalization. So psychoanalysis, molecular genetics, behavioral genetics, biology, developmental psychology, neuroscience, developmental cognitive neuroscience, neuroeconomics. I'll talk a little bit about that later again. Neuroeconomics is where behavioral economic tasks are used in concert with fMRI in order to study social interaction. Psychiatry, clinical psychology, developmental psychopathology, where I find myself home, and family therapy. So with regard to this first criterion, we see mentalization does have potential because it's a construct that can be used seemingly effectively in multiple disciplines. As I said, translational research needs to work from bedside to bench as well as from bench to bedside. I'm going to spend a lot of time on bench to bedside, so I just briefly want to talk about bedside to bench. Mentalization as we know it today in the context of mentalization-based therapy really was packaged for the first time by Peter Fonagy in 1989 and in 1991 when he for the first time wrote about it in the context of borderline personality disorder, which then stimulated the bench work that I'm going to talk about next. So according to this second criteria then, that that a construct needs to be able to work from bed to bench, from bedside to bench, and both from bench to bedside, we see mentalization does have its birth at the bedside really, and then really stimulating the bench work afterwards. So getting into bench to bedside then, really talking about multidisciplinarity. A theory of mind, as I said, has its origins in evolutionary psychology, where it was studied for the first time with chimpanzees, Premack and Woodruff coining the term theory of mind in 1978. So the first task, as it were, was developed in evolutionary psychology, the first task of mentalization. We then see the developmental psychologist developing tasks. This is the Sally Ann task that was published in 1983 by Wimmer and Perner. Which was then picked up by the autism researchers to show that individuals with autism have difficulties in theory of mind, as well as younger children. Children before the age of 4 had difficulty passing the traditional theory of mind task. We then next see tasks being developed in other disciplines like neuroeconomics. This is a classic behavioral economics task I'll talk more about that a bit later. But this is then picked up by researchers in borderline personality disorder in order to study social interaction in BPD. So we see this development of tasks that people are starting to translate. It comes from developmental psychology, from basic behavioral neuroscience, and from evolutionary psychology. And researchers that have clinical interest are picking up these tasks and transporting it over into the clinical realm. A task that I want to stand still at for a moment is the movie assessment for social cognition. Again, a basic science task that was developed at the Max Planck Institute in Berlin. It's shown as a video. I break it down like this because I don't always trust that things will go okay. Research participants are given this video. It takes about 15 minutes if you were to play it from beginning to end, but it gets stopped along the way. So we tell people you will be watching a 15-minute film. Please watch very carefully and try to understand what each character is feeling or thinking. You'll meet each character. This is Sandra, this is Betty, this is Cliff, and this is Michael. The film shows these 4 people getting together for the Saturday evening. The movie will be stopped at various points and some questions will be asked. All of the answers are multiple choice and require one option to be selected from a choice of 4. If you are not exactly sure, please guess. When you answer, try to imagine what the characters are thinking or feeling at the very moment the film is stopped. So people will see this in vivo. The first scene, for instance, is a young woman. She's attractive. She's named Sandra. She opens the door. Upon opening the door, a man who looks to be around the same age enters the house. And before she can really answer, he compliments her on her hair, and he says that she looks terrific. She then touches her hair and starts to say something again, but he compliments her again that her hair looks very classy. And you don't get the benefit of seeing the full video, but perhaps some of you can just go by her expression in her face. I sometimes let people guess which one it is, but I won't do that today. So the research participant then chooses A, her hair does not look that nice. Now, if you think about that, in the question, what is Sandra feeling, that would be considered a no mentalizing response because it really doesn't make use of mental state language, and it's really far removed from understanding what really is happening between these 2 people. B, she's pleased about his compliment. If you did choose A and you're a clinician, think again. B, she's pleased about his compliment. That's an under-mentalizing response. She kind of looks pleased, but there's more to her facial expression. I think you would agree. There's more ambivalence in her facial expression. So yes, if you're a clinician, you chose B, think again. C, she's exasperated about Michael coming on too strong. So where the other 2 were no mentalizing and under-mentalizing, we call this hyper-mentalizing. That's making more of the situation than what is in the data. So this is over-interpreting. I'll come back to this a lot of the time. The rest of the talk will focus a lot on hypermentalizing. But this is the hypermentalizing response. D, of course, then she's flattered, but someone taken by surprise. That would be the accurate mentalizing response. So all of you that are clinicians and got that one right, you can feel confident that you're a good mentalizer. So when we then use this variety of tasks in research with borderline patients, we do see deficits or impairment in mentalization. And I've just kind of listed out a few of these for you. There's a lot of good reviews out there that summarizes the mentalization impairment in borderline personality disorder. So first of all, alterations in emotion recognition, which is subsumed under the broad umbrella of mentalization. Negative bias towards, or a bias towards negative emotions when reading the faces of other people. In terms of verbal descriptions of other mental states, borderline patients sometimes show impairment. Error patterns in facial recognition have been shown. In morphing studies where a facial expression changes from neutral to another expression, borderline patients seem to have a slight bias towards anger expressions. In multimodal studies, borderline patients have been found to show their biggest impairment, and this is when they have to deal, like in the MASC, the Movie Assessment for Social Cognition, they have to deal with a lot of information at the same time, facial expressions, what people are saying, the narrative of what is happening. When there's a lot of information in a task, borderline patients seem to struggle the most. The less information is in a task, the better they do. In fact, in some tasks, like the eyes test, where they just have to recognize emotion expressions from the region of the eyes, borderline patients actually surpasses healthy controls. So the more information there is, the bigger the impairment. These alterations in emotion recognition have been downwardly extended to adolescents. There's been fairly good data showing that adolescents seem to have the same problems when they have BPD traits. And then in mentalization proper, we do see, using these classic mentalization tasks, the FOPA tasks and empathy. Hariri, for instance, showed impairment in cognitive but not affective theory of mind. Using the MASC, Preisler and al. Showed impairments in theory of mind. Dixon Gordon showed in a really good study how when the affective arousal, like Arietta spoke about this morning, when the affective arousal goes up, the mentalization goes down. So in a lot of borderline patients, you don't see mentalization being impaired until the attachment system is activated and the arousal goes up. And then in an fMRI study, very nicely was illustrated hypoactivation of the mirror neurosystem, which is considered to be a mentalization circuit, but hyperactivation of the amygdala symptom, again, as the arousal goes up in the task. And then in our own work, we have focused on hypermentalizing. So what we've done was we've showed the MASC to adolescents with BPD and adolescents without BPD psychiatric controls. And what we found was that borderline adolescents typically chose the hypermentalizing response. And that was for us an exciting finding because there's been mixed findings for mentalization in borderline. But a lot of the studies would not request research participants to actually choose between no mentalizing, low mentalizing, and hypermentalizing. But when you actually give those options to patients with borderline, they tend to go for the hypermentalizing response. So this is just a little bit of data that shows that, and I'm just going to draw your attention to the BPFSC. That's our borderline traits measure for adolescents. And as you go down to the total correct mentalizing, you can see a negative correlation. So as borderline traits go up, correct mentalizing goes down. Hypermentalizing at 41, that's a very high correlation, and no correlations with no mentalizing or less mentalizing. So we, in this study, try to suggest that really the deficit in BPD is one of hypermentalizing rather than one of no mentalizing or undermentalizing. And I'm going to talk more about hypermentalizing shortly. We put this into 2 regression analysis. The take-home message here is, here we have borderline traits as the dependent variable. Here we have diagnosis. We know there's a debate or whether we should look at this from a trait-based view or from a diagnostic point of view. So we tested it both ways. And we controlled for externalizing and internalizing problems. We did that to make sure that the finding we're getting is not due to other psychopathology. We know that BPD is very comorbid with other psychopathology. We still had the hypermentalizing finding. So that's the take-home message there. So starting to then fill out this translational model for BPD. Here, I want to draw your attention then to hypermentalizing. This is the contribution we've been making a lot of in terms of the neurocognitive endophenotype. This is alongside many other mentalization neurocognitive endophenotypes that research has shown: anomalous emotion recognition, reduced trust decisions, hypermentalizing, alexithymia, problems in metacognitive capacity, social cognitive biases, and rejection sensitivity. So, moving on, the integration of biology. So what I've done here, you've got the 9 symptoms that Emily also presented at the beginning of the day. there are several genes that have been identified to be affected in BPD that's also related to mentalizing capacity. So the basic scientists who do genetic research on social cognition and mentalization have identified some genes that are associated with poorer or better mentalization capacity. And it turns out that many of those genes are also associated with BPD. The same with the neurobiological endophenotype, reduced ACC activation, amygdala activation, which I talked about earlier, reduced orbital frontal cortex activation. These are in response to theory of mind tasks, and we know that they're also affected in BPD patients. I'm going to just stand still a little bit at this one, reduced insular activation. This is a study where we used this behavioral economic tasks from basic science, and we gave this task to BPD patients and healthy controls. In the task, there is an investor and a trustee. The investor gets $20. The investor needs to decide how many of those he or she, well, it was all female study, so how many of the $20 she wanted to share with her, with the trustee. The trustee was anonymous in this case. Whatever gets sent to the trustee is tripled on the way. So if I have $20 and I decide to give $10 to you, you will have $30. You then get to decide how much or how many of those you want to send back to the trustee. And this game is played 10 times over. So if you think about it, what needs to happen is we need to build trust across these 10 rounds. If I, as the investor, am going to give you a low offer of $2, you're going to not trust me and feel a little bit hurt by the fact that I'm only sharing $2 and I keep $18. But it's in the investor's, to the benefit of the investor to actually invest that money because it's tripled. So if the investor invests, the investor has more likelihood of getting money back. So it's really a very delicate game across 10 rounds to build trust. So what happens when borderline patients play this game? So what happens naturally in this game is that there are low offers. Sometimes the investor keeps $15 and only invests $5. That's a low offer. Gets tripled, of course, so the trustee now has $15. So what can the trustee do? And I want you to reflect a little bit on what you typically do, just for fun. But one of the things that healthy controls do in that situation is they coax their partner back into the game. So they get a low offer, and instead of walking off in a huff, they decide, I'm going to send a signal to my partner saying that I want to be friends. Hey, what are you doing? You're giving me $5. I'm going to give you back everything. I'm going to give you back everything and send a signal. Hey, let's be friends. Come, the next round, give me more money. That's what healthy controls end up doing in the game. The borderline patients do not coax in the game. What we found across the 10 rounds is that if you invest, if you coax, you get more repayment on the next round. Here we see the difference between borderline patients and healthy controls in terms of coaxing behavior. Turns out that coaxing is associated with insular activity in the brain. So this is the healthy controls here. There's insular activity in the brain that's associated with coaxing behavior, and you see that's absent in the borderline patient. So if you will, the insula has a lot of jobs in the brain, but one of the jobs of the insula is to tell you, in our interpretation of this data, that there's a break in the relationship, there's a rupture in the relationship, and you need to repair. And borderline patients in this study did not show that insular activation. So we're busy filling out this translational spectrum, and we are trying to find a neural network component or variable that can explain borderline patients' behavior, and this is one example of that. Here we see this also related to interpersonal trust scores. So borderline patients, just when you ask them, so looking at the behavioral phenotype, when you ask borderline patients, do you trust your partner, they tend to say or have lower scores. And what they invested in their partners was also at the behavioral level less. So trying to connect again the behavior to what's going on in the brain and later on to what's going on in session, which we will get to. All right, the next criteria, so far just to recap, translational research needs to be multidisciplinary. It needs to work from bedside to bench and from bench to bedside. I've tried to show those two criteria. The biological component needs to be integrated in a meaningful way. Fourth, translational research works best when it's developmental. As you heard this morning from Arietta, mentalization-based approach is, in its essence, developmental. And I like to show this model, which Peter Fonagy and Patrick Luyten published in 2009 in Development and Psychopathology, because it really kind of captures the mentalization-based theory very nicely, and how it leads to BPD. So here you've got your 9 criteria, and you have distal factors. It's a developmental psychopathology model, so you've got distal factors and proximal factors that interact with each other. At the distal point, you have attachment disruptions, which Arietta spoke about very nicely this morning, as well as constitutional factors, which we heard very nicely from Francesca this morning. Sensitive children, children who are sensitive, and they are in an attachment relationship where a parent, for whatever reason, cannot respond to the intensity and the sensitivity of the child. And we have these attachment disruptions, which then leads to a poor self-other differentiation, hypersensitivity to the mental states of others, constantly scanning other people, what are other people thinking about me, trying to control other people, to think certain things about them, low threshold for attachment activation and controlled mentalization deactivation, with impairments in integration of cognition and affect. So the central engine here that then keeps BPD going and leading to these pre-mentalizing modes of social cognition. What are the pre-mentalizing modes of social cognition? They're a pretend mode. Pretend mode sounds like mentalizing, but it isn't mentalizing. So a good example of a pretend mode would be when you have a person trying to be empathic, but it's really coming out of a place of manipulation in order to get a certain behavior from another person. So if you go by mental state language, it sounds like a mentalization, but it really isn't if you dig a little bit deeper and see it in context. That's pretend mode. Psychic equivalence is a confusion between what's in my mind and what's really happening out there. Believing, it's a little bit like we find in OCD, where there's thought-action merge, where what is happening is real, rather than I have a mind that is separate from what is happening out there and I can dissociate the two. And then finally, teleological mode, which is really just goal-oriented behavior. So again, taking the mind out of the equation and just focusing on the behavior. So those are the 3 pre-mentalizing modes of social cognition that then keeps the symptoms going. So this is to illustrate to you that mentalization is by nature a developmental approach. It's also developmental in the sense that it's got a normative map charted out for mentalization-based development. It's best charted out for preschoolers. That's just one of the maps that are out there, and there is data now for adolescents as well. It obviously gets a little bit more complicated in adolescence and young adulthood, but this process is not complete until people reach their mid-20s. So then this criteria then, that translational research works best when it's developmental, we see again potential for mentalization to meet this criterion. Does mentalization have the capacity to accommodate mediators and moderators? One of the most important mediators is emotion dysregulation. So in our study that I talked about earlier, we did look at emotion dysregulation through the difficulties in emotion regulation scale, and we found that hypermentalizing affects BPD through emotion dysregulation. So you can imagine that a person hypermentalizes, gets more affectively aroused, it becomes harder for them to regulate their emotions, and the BPD symptom levels go up. So that's in terms of mediators. There are, of course, other mediators that is going to affect mentalization. Research has shown stress reactivity, experiential avoidance will affect mentalization, identity diffusion will affect mentalization. Moderators, known moderators of mentalization capacity is gender. Do the women want to guess who's better at mentalizing? Age is a moderator. Maltreatment is a moderator of mentalization. And then family variables, and I'm just going to give you a taste of that again. So in this study, we added to our model attachment. So we did child attachment interviews with our adolescents, and here you can see this is the attachment coherence subscale. You can see a high negative correlation with hypermentalizing. As hypermentalizing goes up, attachment coherence goes down. And in the way that this is measured in the CAI, of course, we code it by looking at how coherently someone can make sense of their experiences with their attachment figure. And you can see here then BPFSC, of course, again, borderline traits associated with hypermentalizing as well as emotion dysregulation. And when we put that into a multiple mediational model, you see this very nice model here where hypermentalizing is again mediating the relationship between attachment, security, and borderline features. Emotion dysregulation in this model did not do that, probably because of the relationship between these two variables. All right, so moving on to the next criterion. So yes, we've got all this basic science in support of the mentalization construct. Now, can we take this construct and translate it into a malleable treatment target? So what we've done is to review all of this literature on BPD and mentalization, and it is mixed. And we've distilled these 4 characterizations of mentalization that we find in BPD in order to try and develop a treatment target. If we need to say, what are we going to target in mentalization-based therapy, what should it be? So we first of all came up with the conclusion that social cognitive deficits are apparent under high conditions of high arousal. So if a borderline patient is not necessarily highly aroused, they may be an excellent mentalizer or even a superior mentalizer. And you have heard people talk about the borderline paradox, where clinicians have reported on how wonderfully sensitive borderline patients can be in interpersonal situations. But the moment the attachment relationship is activated or attachment context is activated and arousal goes up, mentalization goes down next. Social cognitive deficits are apparent only under conditions that require integration across different cognitive modalities. Like I said before, in simple tasks, borderline patients do really, really well. It's when things get complicated and integration across cognitive and affective modalities, across self and other, the space between two people, once that starts happening, it gets more difficult for patients with BPD to mentalize. Social cognitive deficits in BPD reflect a lack of integration between these social cognitive systems, and individuals with BPD therefore do not suffer from deficits per se. It's not that, like autistic individuals, they can't mentalize. It is that there is an over-attribution when the affect gets aroused, which we then call hypermentalizing. So we've just put it all in a visual representation with the associated literature. So a person gets into an emotionally intense interpersonal event. It leads to a lack of integration across cognitive modalities, a reliance on controlled, explicit social cognitive reasoning when the gut needs to be relied on, or sometimes a reliance on the gut when the person needs to be actively engaging in controlled mentalization. So it's a lack of fit between what the social situation is asking me to do with what my brain is doing, which leads to errors in interpretation and then hypermentalizing. All right, so how do we define hypermentalizing? Excessive theory of mind is how it was originally defined by Diabeck, who developed the mask, or social cognitive processing that involves making assumptions about other people's mental states that go so far beyond observable data that the average observer will struggle to see how they are justified, or over-attribution of mental states to others and their likely misinterpretation, or overactive and exaggerated resonance with the mental states of others due to confusion between self and other mental states. All right, what does it sound like in practice? So remember, we're trying to get through this whole translational spectrum for mentalization. This comes out of Sune Bo Hansen. He's a Danish psychiatrist working with mentalization-based therapy. So the therapist says, so tell me about the difficult situation when you met with your ex-boyfriend. This is a 17-year-old girl that he treated. It seems to me that it was a bit frustrating for you to meet with him. Is that right to put it that way? Gina says, he met with me just to see that I was still in pain. The therapist said, what was it like to meet with him? Gina says, awful. I mean, I spent 2 hours in hell. He kept telling me about his life and that he's going out and has a lot of new friends. So annoying. I hate him. And he doesn't respect me. Just wants to bug me. Therapist says, that doesn't sound nice. Did you feel anything in particular in that situation? Gina says, I fucking told you I hate him. What is it that you don't get? Gina talks very loud and she seems agitated. The therapist says, wow, it seems to me that you are affected with what happened here. Sorry, it wasn't my intention to annoy you. Gina says, you all say you are sorry, but it is a lie. She talks loud and fast. John, the ex-boyfriend, says he is sorry that we could not stay together. Bullshit. He's not sorry about anything. Lisa, the contact person at the institution, says she wants to help me and tries to understand me all the time. She's not trying to understand anything or help anybody. You and all that mentalizing. The therapist said, hold on for a second, Gina. This is going really fast. And I can't figure us all out. Can we please pause for a second and look at what happened here? And then Gina says, I don't want to pause anything. I know what you're up to. You want to blame me. Tell me that it's my own fault, that I have to work it with myself, that we should try and look at it together. She makes a face. No way. You obviously don't want to help me. That is clear. You just want to talk. I need action, teleological mode. Lisa doesn't like me. I know for a fact. There you see psychic equivalence. And Carl, head of the institution, ignores me on purpose. And then Gina starts to cry. And so you can see that she's in this pretend mode. There's a lack of what is really in the mind of the therapist right now, and she is ascribing thoughts to the therapist and intentions to the therapist that the therapist does not have at that moment. So a clinical example of hypermentalizing. So can we target this disease mechanism? If it's a disease mechanism, one of many disease mechanisms in BPD, can we target it in treatment? So what we did here is we took the mask and we gave it alongside a bunch of other mentalization measures because we're interested in seeing, is it hypermentalizing really, which is the thing we need to target. So this is a vignettes task. This is an empathy task. Someone asked earlier about what's the difference between empathy and mentalization. This is an empathy task, and this is the eyes test. And on the map of mentalization, implicit, explicit mentalization, automatic, controlled mentalization, internal and external features that one focus on in mentalization, you can see they all lie on a different place in terms of the mentalizing landscape. What we found was really that it was really only this one that was sensitive to treatment. So it could be a property of the task, that's possible, but it could also be that it is hypermentalizing, which is what we reduce in our therapy, whether we do DBT or whether it is we do MBT or anything else, it is the hypermentalizing that we address. So here we just see simply a reduction for both BPD and non-BPD adolescents in hypermentalizing. We did a very simple thing, which was just to correlate the change in hypermentalizing and BPD features, and they were highly correlated. So we concluded through just this inpatient treatment that we do at the Menninger Clinic, we are bringing down hypermentalizing, and we're doing so at a higher rate for borderline kids than non-borderline kids. All right, on to can we capture the behavioral phenotype? So we've got a treatment target that we think we may target thoughtfully. Can we capture it, or do we need to go do fMRI tests to capture it? Or the mask, which takes a long time, 45 minutes when you run through the whole mask. Can we capture it in any other way? So we've been working on developing a hypermentalizing measure. We've identified 5 components: over-concern with the mental states of others, over-interpretation of other mental states, inflexible certainty in own beliefs about others' mental states, acting impulsively on assumed mental states of others, and second-guessing or over-interpretation of own mental states. Here are just some of the examples. Importantly, we do this in the attachment context. So adhering to the model of attachment-based mentalizing, we do this in the attachment context. I worry a lot about what my parents are thinking and feeling. Overinterpretation, my parents often say I overinterpret interpersonal situations with them. Inflexible certainty, my feelings about my parents are thinking is hardly ever wrong. Acting impulsively, I easily lose control in situations with my parents if my feelings get hurt. Second guessing, I often feel angry at my parents because I feel confused about my own feelings. And we've got a parent version, boyfriend-girlfriend version, and a closest friend version. So we've done this in 2 studies now with 690 undergraduates just to get a feel for it. We did the MASK, the theory of mind task that I showed you earlier, and we expected a negative correlation with correct mentalizing, a positive correlation with excessive mentalizing, and no correlation with less TOM or no TOM, because it's supposed to be the hypermentalizing component of mentalizing. We did acceptance and mindfulness, emotion dysregulation, and poor reflective function. We expected people to be poorer at emotion dysregulation and acceptance, and poorer at reflective function when their scores in hypermentalizing were high. This is just basic psychometrics which were good for the measure. And here's the construct validity. So if you just go down number 4, which is the hypermentalizing, you see exactly what was expected. For correct mentalizing, the negative correlation. Excessive theory of mind is uniquely correlating with it, not the other 2 subscales of the experimental task, and then the expected directions with experiential avoidance, emotion dysregulation, and reflective function. So we were encouraged by this finding. We then, let me quickly just show you. This is just the data for the romantic, closest friend, and the parents. And what came out of these correlations is that we think the parent version of this in adolescence is probably going to be the most robust or valid. So if you have to choose between the 3 versions, it's probably going to be the parent one that is going to give you most bang for your buck in terms of BPD. In study 2, we then took this to the adolescent population, 35 adolescents meeting DSM criteria for BPD, 48 psychiatric controls without BPD, and 83 healthy controls. We did the CI-BPD, a diagnostic interview for borderline, and then the hypermentalizing. And here's just the grand total, and you can see this very nice pattern with the healthy controls, lowest on hypermentalizing. Other disorders do hypermentalize too. You get the psychiatric controls, and the borderline kids are highest, and that's across romantic partner, parents, and closest friends. So again, an encouraging result that we can capture this behavioral phenotype in this translational spectrum. We don't have to go do fMRI or genetics analysis, but we can potentially capture something that relates to all of those other levels of analysis that we've been looking at. So there's the full model then in terms of what I've been talking about. I want us to then just get to MBT. So closing the loop, many of you are familiar with it. It's a collaborative approach formulation. You want to, in the therapy, help patients identify when they are in a non-mentalizing mode. The general stance is one in which you are constantly monitoring affective arousal, because we know that if the affective arousal gets too high, then you'll have to bring the affective arousal down in order to effectively do the mentalization-based therapy. And I'm going to show you a little video where you see Anthony Bateman doing that rather ineffectively. Anthony wanted me to say that to you. We know the core of mentalization base is a stance of curiosity, so a not knowing stance. You are not the wise one in mentalization-based therapy, but it is collaborative, and you are working things out in the context of the relationship with the patient as you go along. Identification of the mentalization poles, and then there's a trajectory of sessions that start off more structured and gets less structured and more relationship-focused as you go along. Specific strategies just for hypermentalizing, because I'm busy really focusing on that for the treatment target. Pretend mode then, Ideas form no bridge between the inner and outer reality. The mental world is decoupled from the external reality. Dissociation of thought, hypermentalizing or pseudo-mentalizing, reflects the explicit mentalizing being dominated by implicit, inadequate internal focus, poor belief, desire, reasoning, and vulnerability to fusion with others. And this is managed by interrupting the non-mentalizing process. So encourage the patient to step back from this collapsing. Reminded me of Francesca's stop. Step back, we call it pause and rewind. Step back from this collapsing of appearance and reality, drawing attention to the patient's vulnerability to emotional contagion, drawing attention to their difficulty in inserting doubt or uncertainty into the process of inference. Help the patient integrate intense sense of affective knowledge with more reflective and cognitive knowledge. The aim for the integration of cognitive belief states, which are dominated by the agent, and affective knowledge, which is dominated by the inferences drawn by their feelings. So again, just get the poles integrated again between self and other, affect and cognition. Work towards shifting the patient's thoughts and feelings between the self and the other in a consistent, flexible way, and differentiation between self and others.
For a first question, there's a question about whether there are, how hypermentalization compares with CBT. Is this working? This is working. There we go. How it compares to things like personalization or catastrophizing, whether there are certain red flags or kind of buzzwords related to thoughts that are suggestive perhaps of hypermentalizing, that someone is hypermentalizing. What's that connection?
Well, I do think there is a connection, and I was psychodynamically trained in South Africa before I then moved to England, and there I was trained as a CBT therapist, and I've always, the idea of hypermentalizing always resonated for me with the idea of mind reading. So in CBT we tell people one of the cognitive distortions that people engage is mind reading, and we've often thought about that in the context of social anxiety. So people with social anxiety tend to mind read. They're constantly scanning other people for what they might be thinking and attributing thoughts to them. I think it's exactly the same. I think it's useful to use CBT. I think for me, really, we don't have to box in the therapeutic modalities like we've done in the past. I think there's a lot of overlap, and what perhaps is new is thinking that borderline patients mind read. I think we in the past thought that borderline patients don't read minds, but they do. But they just overread minds, or they attribute too many mental states to other people. Yeah.
Thank you. Could you comment on whether there's any difference between mentalizing and in DBT validation, being able to speak about someone else's experience?
Well, you know, I do think there is a slight difference in the sense that I think the outcome's the same. I think mentalization will validate when you, but the difference is that mentalization takes a stance of curiosity. So you're not really saying that is really hard. I would have cried too if that happened to me. You are just saying, oh boy, what were you thinking? I mean, how did you handle that? I don't know what I would have done, but what did you do? Or what were you thinking? What were you feeling? So it's a curious stance rather than immediately validating it, because it comes out of the idea that by getting the patient to reflect themselves on their own mind and what was happening in the situation in the mind of the other, you can get movement doing. I think in the end both will validate the patient. So there may be some overlap there, but I think in DBT there's perhaps a clearer immediate validation happening. We can ask Alec or Francesca. I don't know.
And perhaps Alec will comment when he comes up as well. Could the hypermentalizing task or measures be used diagnostically?
There's no data to that we've just developed a measure this year. The mask, people have been using it in clinical practice in order to just get a sense of people's mentalizing style. It's complicated because you have to get permission from the developer and there's no norms. So I think part of evaluating mentalization as a translational construct is the development of off-the-shelf measures, and that's what we're trying to do, to create norms and see whether we can use these measures in clinical practice to either identify someone's style, but also then importantly to see if there's a reduction in that style over time.
Is there any information available yet about mentalization for adolescents specifically and from clinical trials?
There's been one RCT conducted by Trudy Rousseau and Peter Fonagy that was published, was it 2012, in the Orange Journal or Journal of the American Academy of Child and Adolescent Psychiatry. And so that's the RCT that's been published. There's a couple of other groups across different countries that have been doing mentalization-based work for adolescents. I'm a co-investigator on a trial that we're now doing in Houston. So I think there'll be more data coming out, but the only RCT that's out there right now is the one with Trudy Rousseau. So it's Rousseau and Fonagy, I think 2012. And folks who want that can email me for that.
Okay, and perhaps it's the after lunch experience. Those are our questions.
Sure.
Thank you very much. You'll be joining us again on the panel. If other people have questions that come up, they can come there. Thank you.